we are living now in the era of TKI discontinuation, because no doubt that particularly for younger patient, and for younger patient I can say below 50 or below 60 is not an graphical concept. From the time of diagnosis, the first endpoint is, or if you want, the first question is, how long should we continue with TKI? And now physicians can answer differently from the past, when overall survival was the endpoint. And physicians and hematologists can modulate their answer according to the age, to the risk and expectation of the patient. So inducing in the best available way, and probably second generation TKI are a better option, nilotinib and dasatinib versus imatinib in this field. So inducing a deep response and maintaining it sufficiently long, so the duration of TKI is important, maybe 5 years or 6 or 4, not yet ruled out, and at a given point the patient can stop the treatment. This is particularly important because now we have the opportunity, thanks to patient advocacies, they are so active in CML, and I believe that patient advocacies in Europe started with CML patients, and they will then relaunch the information, and really on an educational point of view they are informative advocacies with their patients. And so this is a joint effort to optimize, in this case, not the treatment but the treatment discontinuation. Then as far as second line treatment, we have new opportunities, and I would like to, just to mention, ponatinib is still considered a third line in Europe, but maybe that would be an ideal second line treatment once the issue of the dose and cardiovascular toxicity will be completely, redefined or ruled out. Second point. Third point is that monitoring, now we are in a highly mature period, and the harmonization of the molecular responses, at least across many countries in Europe, has been more or less fully accomplished. So treatment discontinuation, the role of the advocacies in relaunching the information, and an adult molecular monitoring, adult and harmonized. During the CML session Saturday afternoon will be presented for the first time by Professor Hohaus a trial with nilotinib in early chronic phase CML, a trial performed in Europe, a huge number of patients. And what is important to underline is that the learning curves of doctors using nilotinib is now in a better position than before. So results in terms of deep response, even after 12 months and 24 months, are much better than those achieved with previous experiences with nilotinib. So second generation TKI really now are expected to fully overcome what imatinib did in the past. Imatinib is and will remain a very important drug in CML, but not the only one. So second generation, and nilotinib in this case will be presented at a youth trial today, will be the first choice for a number of patients, particularly those non-low risk, and all of them who are expecting or are waiting for treatment discontinuation in their future. So